Hey there, and welcome to the Agentic Voice podcast. My name is Kristen Ruiz. I'm here with my co-host, Geneva, Mayne, and in today's episode, we are going to be exploring how to recognize the signs and symptoms of dissociation within a trauma-informed approach. And our special guest today is Elisa Monti. She's a voice-specialized experimental psychologist with a PhD from the New School for Social Research. Her work focuses on the relationship between psychological trauma and different measures of voice, and her mission is to further our understanding of this relationship. Elisa is a certified performance wellness therapist trained in the Montello method for performance wellness and in vocal psychotherapy, and she was trained by Dr. Diane Austin. Elisa is also the co-founder of the Voice and Trauma Research and Connection Group, Incorporated, and the Monti Bianchi Performance Wellness, LLC. And Elisa collaborates with numerous scholars and scientists, including the Helou Laboratory at the University of Pittsburgh and New York Speech Pathology.
Thank you.
So why don't we go ahead and check in on what's new and good? So Geneva, what is new and good in your life these days?
Well, it's new. I don't know if it's necessarily good. So, I've been away all summer. And one of the things I was really looking forward to coming back home is like being in my gardens, because I love to garden. And this new home that we were able to get earlier this spring has some lovely gardens. And I was kind of bummed out when I came back to see everything kind of wilty, because it's been dry
Summer up here. Yeah,
right. But then this fall we've gotten some really nice rain, so everything is coming back in and it was looking lush. And so like I get up in the morning, I look out the window, I admire the gardens. We have one bed that's like full of hostas. Next morning I got up, I'm like, it's all gone because deer got at it.
Yes.
And I was like, oh, look at that. Completely eaten. So it's new. I wasn't too disappointed though. I kind of chuckled to myself like, wow, okay, I'm learning the tricks of this house.
Yeah.
Aging deer and wildlife. So
and you made their day. I heard if you put if you pull hair out of a brush and like put that in and around and like garlic scraps, I heard that can help.
So, I've never heard that, but
I don't know.
Nice being out, around nature, but these are the things you have to think about. So
yeah, we had a woodchuck that ate all of our cucumbers, so we planted cucumbers for the woodchuck. So,
oh, yeah.
That's so sweet. And Elisa, what's new and good with you?
What's new and good with me? Well, I'm here with you both, which is amazing.
Lovely.
And something that is new, I am actually in the process of trying to close on a very, very small investment property in Philly.
Oh, wonderful.
It's a very small studio apartment, and I am obsessed with everything that is small, like tiny homes and things like that.
That's so cool. I love those shows.
Yeah.
So I'm like, I want to take this space and make it super functional, make it like really, really livable despite how small it is.
Yes.
And so I can't wait to close and have fun with it and spend time figuring out every square inch.
Right.
Oh, absolutely. And figuring out like multifunctional things, right? Oh,
Absolutely.
I love it.
Cool.
Yeah, and for me, I was trying to think, there's some work things that are new and good, but I was like, what I'm actually feeling is really making me happy today is I found a coffee alternative. I've been looking for alternatives, just trying to do things that are helping me with like anti-inflammation, stuff like that. And so I found dandelion and chicory root tea. And it has the earthiness of coffee without like some of the caffeine and some of the other stuff. So it's actually been quite lovely and I've been enjoying it, and I've been a little cold. So I'm very happy to be drinking it. So that's a simple thing, but I'm finding joy in simple things these days. I think 2020 changed my perspective by quite a bit. And so really just enjoying the little things.
Awesome.
Yeah.
Amazing.
So, Eliza, one thing that I would love to hear about from you is how did you go from, performance world into, the world of, research and psychology? And can you talk to us a little bit about your journey?
Sure. Thank you for asking. So it all started when I moved to New York when I was 18 years old, and I started going to the American Musical and Dramatic Academy. I was
Mm-hmm.
this Italian chick who barely knew the language. Actually, not at all in the beginning.
I mean, that's
Uh,
amazing.
but I learned through, being surrounded by American students. And I loved to sing, as did all my peers. And when I was there, I started really observing that a lot that goes on with voice seems to be so related to emotions and somebody's history.
Mm.
I remember moments where I saw my peers sing a song that I knew they could sing perfectly. So I was like, it's not a voice problem because I know you can sing the song perfectly from the first note to the last note. When something happened for them that clearly brought them into a different space emotionally, their voice was out the window.
Interesting. Yep.
And yeah, and I remember thinking, this is very interesting, and trying to sort of ask questions to other people, and other people seemed very disinterested in the topic, and everyone was very much about the technique and put it in the mask and all that kind of stuff. And I was like, well, sure, there's a lot of practicalities that can be implemented, but this is not happening because of the voice, it's happening from somewhere else.
Mm-hmm.
And that intrigued me a lot. So when I had my certificate from AMDA, I finished my undergraduate studies at the New School, and I started taking a lot of psychology, a lot of music therapy. And then I decided to get my master's in psychology.
Okay.
And through colleagues and conferences, I started realizing that the language of research speaks very loudly. It's not the only, language that matters, but it's important. And I realized that I wanted to, become an experimental psychologist. And then eventually I also became a certified therapist through vocal psychotherapy and performance wellness. That kind of happened later.
Okay.
But yeah, in the beginning, I was like, I just want to somehow get my hands dirty and investigate a little bit of this stuff because it's just so interesting to me.
Absolutely. And I've heard so many singers talk about how like they'll know a song inside and out. They'll go to present it and something happens. Sometimes they call it a head game or sometimes it's performance anxiety or like whatever that thing is the thing that they knew that they could do doesn't show up. And then they're like, we're all like, when that happens, like, oh, I wish you could have seen me in that other room. I mean, it's something we talk about all the time. So to
Mm-hmm.
have researchers looking to connect the dots between the physical instrument and the rest of the human experience, it's really powerful. We're grateful for the work.
Thank you. I appreciate
Yeah.
it.
Yeah.
I feel very, very grateful that I get to help others.
Hmm.
And that happens through practice, that happens through the conversations that we all have, because this is one of those spaces for sure. And through connecting those dots, I'm just so happy that I get to spend my days thinking about this, talking about this, and through this knowledge, help some people who are in need.
Hmm. Absolutely.
Nice. Okay. In the middle of all those journey things, you were able to start the Voice and Trauma group and do a documentary as well. Can you talk a little? I'm a little bit intrigued about that part of your story. Can you talk a little bit about that?
Thank you. So with the Voice and Trauma group, it's funny because I remember when I got the website from Squarespace, I was like sitting in a hotel room with my aunt, and I thought, this seems like a great thing to do to get this website. Because I remember thinking, I really want a space where we can have conversations about voice and trauma. But the reality is, there's no conference, there's no journal, there really wasn't a space. I mean, a lot of people are interested in this topic, but it's almost like stars, in the sky that don't really form a constellation yet.
Mm.
Someone from a speech language pathology perspective, someone who's a vocal psychotherapist, someone who's a trauma researcher over here. But the cohesion, that the common space wasn't there. And the simplest way to start was with a website and Zoom conference type meetings. And that's how we started. And then we were like, it would be great if we were a nonprofit organization. And then we started that paperwork as well, which took about a year and a half.
I think COVID really slowed things down. Yeah.
Oh, yeah.
Mm-hmm.
Absolutely. Yeah, I mean, 10 minutes of paperwork could take 10 months in certain offices.
Yeah.
So, yeah, but it's done. Thank goodness. Thank you. And yeah, with the video, You'll Say Nothing, that actually came out a few years before the Voice and Trauma group was even a thought up here or in anybody's mind. Mm-hmm. I just had the idea that I wanted to interview some experts on this topic because I really wanted to get the word out that this relationship can be a thing, is a thing. We've seen it be a thing in some domains. And I just wanted to create interest in the topic. I mean, as I mentioned earlier, research is a very important language, but the public generally doesn't read research, and so oftentimes doesn't discover that certain topics are of importance or exist.
Yes.
Wow. I love, oh, go ahead, Geneva.
Yeah, I was going to say, even among clinicians, research to practice can take a really long time. 10, 15 years, I believe, is the number people have thrown around. So it's good to be able to have spaces where you can just have a conversation about what's going on, what's current. So that's great.
Well, I think that's the power of discourse, of having these kinds of conversations between researchers, clinicians, and practitioners, is that once the practitioner is aware, they can start allowing that to infiltrate and kind of infuse their practice, which gets to the front lines. So I think that this is great.
Mm-hmm.
Yeah.
Thank you.
Okay. Well, now that we're kind of caught up on your story, let's move into today's agentic practice, which is to embrace a trauma-informed approach. So let me ask you, what exactly is a trauma-informed approach?
There's definitely several definitions, and the definitions keep changing because, as you know, culturally, socially, clinically, we keep evolving. And sometimes what we said a few years ago, we realize now that it's, not the best way to define, trauma-informed approaches. I would say in my own language that definitely being trauma-informed means recognizing that we interact with others. And the question is not if I happen to interact with a trauma survivor, it's when I happen to interact with a trauma survivor, because it's going to happen. Statistically speaking, we know from the numbers that this happens. Some numbers that we even have had for a long time now from the United Nations or the CDC teach us that it's more common statistically to have childhood trauma, for example, than it is to be left-handed.
Oh my word.
Childhood trauma survivors tend to be about 1 in 4, 1 in 5. That is if you lump a lot of experiences together. Left-handers are about 1 in 8, 1 in 9. So the numbers are very, very high, and that's very important to keep in mind. So when we think about trauma or how to define trauma, this is also something that has been evolving throughout the decades. We used to emphasize the event so much, for example, an assault or domestic violence or an earthquake, a car crash. And of course, the event is part of the equation. But the way that we understand trauma today is that trauma is not the event, but trauma is how our nervous system has responded to the event. It's a very, very important differentiation also because this prevents, some from saying, well, this doesn't sound like a trauma, or this doesn't count as trauma. Well, if the nervous system reacts like it is, this probably was traumatic for that person. And this is very important to think about in terms of, trauma-informed practices. As we said earlier, realizing that there's a prevalence of trauma, and the prevalence is very, very high. When we think about how trauma can manifest and can manifest in different ways, for example, people can become what we call hyperreactive, hypervigilant, which basically means that the person is constantly scanning for their environment for signs of danger, and they are sort of prepared in case anything happens, and everything sort of operates from this survival mode. So it's almost like I am ready to act, I am ready to mobilize. But sometimes it can also look like a little bit of the opposite way, or a mix of the two, which is more like immobilizing and becoming sort of more flat, more checked out, more like the person is sort of somewhere else. And that can look a little bit more like dissociation, which is what we're going to be talking about today. These defenses come for different reasons physiologically, but they are coping mechanisms for the person to try and stay safe. Sometimes the hypervigilance comes when the person feels there's a choice. Can I fight? Can I flee? Sometimes when it seems like there isn't a choice, the person will start numbing out and dissociating to try and minimize the pain of a situation that is not escapable, which is one of the reasons why dissociation comes up so much in survivors of chronic trauma as opposed to acute trauma. And knowing all of this stuff also informs practitioners and all other professionals when it comes to policies, practices, procedures, knowing about the stats, but also how to be in space, in the space with trauma survivors. How do I use my body language? How do I use my voice? How do I learn to read the cues? Because sometimes when someone is looking around a lot and seems like they're not really listening, it's not that they're not listening, it's that they have to tend to every single cue in the environment to make sure that they're safe. So the trauma lens approach really helps us understand, okay, this person is trying to survive.
It also helps the person who's, in the room, if they have that lens, that they're not creating the wrong meaning of what they're seeing, so that the interpretation of what they're doing is truer to what is being really experienced by that person, as opposed to assuming, well, they're just not listening. So,
exactly.
Yeah. So there's a benefit on both sides. Can you explain what the word dissociation means?
Yes. So dissociation is, again, we could say a coping mechanism, a psychophysiological reaction, a symptom. I mean, we could label it in many different ways, but it's the idea that it's a loss of integration in someone as a result of trauma in their sense of self, sometimes their awareness, sometimes their memory. It's almost as if you imagine a lot of things that tend to go together, the way that we feel, the way that we think, the way that we remember, the way that we feel that we are ourselves, becomes a little bit fragmented, disintegrated. So that can result in someone not being able to really tune into their bodily sensations, not really remembering important events that happen in their life, oftentimes related to trauma or not necessarily. Sometimes it has to do with feeling that things around the person are not very real, or the person has sometimes sensations that they're not real, or they're disconnected from their body, out of their body. It can also look like identity confusion, or sometimes, even things such as dissociative identity disorder, where there's a fragmentation in identity as a result of the trauma. It can look like many things. It can be someone who's very spaced out, someone who can't recall what they did the day before, where they bought the clothing that they're wearing. And there's almost like a lizard-like energy when someone is dissociated. When someone is in fight or flight, it's more like, a dog ready to pounce. I'm ready, who's coming? I'm ready for you. Or a deer ready to run. But there's something more lizard-like about dissociation. It's like immobilization. Wow. And just, trying to minimize what might come.
Wow. And I think one of the things that we're really kind of coming to understand now, especially from some consensus papers in the speech pathology world, is that dissociation is associated with, or can be a part of, functional neurological disorders with communication symptoms, which primary muscle tension falls underneath. So in
Mm-hmm.
terms of like relevance to our Agentic Voice podcast, dissociation is something that voice care workers might see in the students that we work with, in the patients that we work with, who might be dealing with primary muscle tension, dysphonia, and it can be seen in the people that we work with who might be showing post-traumatic stress, signs of
Mm-hmm.
post-traumatic stress. And then you said it can also occur on its own, correct?
Yeah. Yeah, it makes a lot of sense to me, because if we think about, how much of this has to do with the autonomic nervous system and the fact that that connects to the larynx. And of course, there's so much that we still don't know about this body of science and all of these connections.
Mm-hmm.
But to me, it definitely makes a lot of sense, even intuitively, because if we think about dissociation as, again, a little more veering towards the other side, as opposed to like fight or flight, it's more going to this parasympathetic regulated place, this shutdown place. It's very, very different from this. So we could say almost like overly energized fight or flight reaction. So the idea that something becomes immobilized even vocally. I remember I was listening to a lecture by Ruth Lanius who was talking about this. I thought it was really interesting, and it just sort of sparked my curiosity to learn more. But she was talking about how when someone is a dissociative shutdown state, sort of like the more the person goes in the direction, the less vocal they become. So I thought that was really, really interesting.
Yeah, I think I'm used to thinking of fight or flight with PTSD.
Mm.
Someone who might be very emotionally reactive if they're triggered, and so like one of the things that I'm often thinking about is not matching energy for energy, because you don't know what a person might be going through or dealing with or reliving. But I don't think I necessarily know what dissociative reactions look like in people, because it seems like the goal of this kind of a coping mechanism is to hide or not be seen,
Mm-hmm.
kind of check out. So, what does this look like? And is it something that can be triggered or habitual, like a fight or flight reaction?
Mm-hmm. It's definitely something that happens when there's a reminder of trauma for the person in the room. And when it comes to triggers, we just have no control over what the trigger might be for that person, and this is part of the re-traumatization process, like being very open-minded to a trigger could be anything for this person. So I want to be very mindful, because sometimes re-traumatization occurs through the minimization of triggers, like, oh, come on, is that really that bad? Or sort of labeling a reaction that someone has as too much or exaggerated. So sometimes there can be a trigger, and the trigger could be anything, could be a sound, could be a smell, could be that maybe we as the practitioner are wearing something that reminds the person of someone who hurt them. Very, very difficult to know. It could be a rumbling sound outside if there's thunder or construction. And sometimes it can feel almost as if the person is going somewhere else mentally, like they are presenting as if they're present, but something in their energy suggests that they are being sucked into a different dimension. So they might start becoming very still, and often they breathe very shallowly, and the speaking rate tends to decrease. They tend to talk a little bit less, sometimes anecdotally, of course. They get a little bit breathier, more high pitched. And it's almost as if they're thinking of something else, or they are somewhere else emotionally. And maybe the two of you have seen this sometimes happen in people, and wondering, is this person distracted thinking about something that happened to them yesterday, or is there more to it? And as you said, Geneva, because the person is trying to hide their experience, sometimes it's not so easy to tell, especially if they have learned to mask the experience. something that I have learned within myself, this sounds very countertransference like, but really any practitioner can tune into this, is if I realize that my breath is getting shallow and I cannot feel my feet anymore, sometimes it can signal to me that something is happening with the person that I am sitting with or working with. And
why would that be? Because you're matching their energy, or what's happening? Why that would why you would
I think that would be probably because of psychophysiological forces. I know there's a body of literature that looks into how somebody's physiology influences another person's physiology. And so, I mean, of course, in a voice practice as opposed to a therapy practice, the questions might seem different, but where we would have overlaps is the part where we start assessing how much is this person in touch with their body right now? Are they in their body, or are they trying to separate from their body as much as they can? And the things that happen with dissociation oftentimes are grounding. You know, if the person has been sucked into a past experience that is painful, and of course, in the most extreme situations, you might see someone as if they are literally reenacting a scene from their past. It's to try and bring them back to the present sensory moment, starting with really, really neutral cues. I think shoes are always great because they're so close to the ground and they are around the person's feet. So asking them about their shoes, you know, what do your shoes feel like? Are those comfy? You know, are they warm? Like something that really brings the person back there. Or, oh, I like your earrings. Where did you get those? Like, so that they, wherever they are, they're kind of forced to come back to the present moment. And then gradually, as, you know, that neutral sensory stuff grounds them, then to go back to the voice. Because sometimes I think the trigger is also the fact that their voice means so much to them and it's so close to their identity. And if it links them to criticism or insecurity or very, very serious situations, it's better to sort of glue them back with something more neutral and then come back to the voice.
And that's interesting because, you know, one of the things that we've discussed with Halu Laboratory in the Voice and Trauma group is just this idea of low self-awareness in laryngo responders and people with voice disorders in general. And this is like a marked difference with singers who have a high self-awareness of their body and their breath and what's happening, because that's part of voice training, is to become more aware of those things. But sometimes people who are experiencing voice disorders or who might be laryngo responders who respond to stress or difficulties, you know, with some kind of voice symptom, self-awareness is a challenge. So I can imagine that just practicing grounding techniques in lessons or therapy sessions is just a good practice for this population to kind of gain self-awareness, like you said, in a safe way, like not in reference to the voice, but with just the body in general.
Yeah, definitely. And sometimes objects too can help. Like the reason why I go to clothes and, you know, earrings and shoes, it's because objects feel more neutral than body parts. Sometimes even just reconnecting to the breath can feel scary for someone who's dissociated. And a lot of people who dissociate say, well, breathing, you know, when people say, oh, you're being activated, you have to breathe, you have to relax. But the reality is, if you're all the way into parasympathetic land, slowing down your breath can make you feel even more checked out, even more dissociated. It's like you kind of have to veer the other way. If you're in fight or flight, then yes, breathe, because you are sympathetically driven. You need to bring your heart rate down, your breathing down. But for someone who seems like they're kind of all the way up here, I would say grounding.
You know, that sounds very similar to some of the work that we do with singers who have performance anxiety. And it's that, you know, I never thought of this word being applied to that situation. But that idea, like Geneva, what you said is, yes, singers are trained to have resonance awareness, to be aware of the body in motion, to be integrated. And in moments of performance anxiety, one of the things that's so upsetting to the singer is that disconnection, not being able to find it in that moment. And so the grounding exercises to feel your feet, to wiggle your hands, to do things that help you like reconnect and integrate back into your body. So this is super interesting. Do you see this as connected to performance anxiety as well?
Yeah, absolutely. Yeah. Sorry, was that for me or for Geneva?
Oh, sorry, that was for you. I mean, it's for either of you. But yes.
I definitely do see this a lot. And I do see sometimes a lot of mix where it seems that somebody is for a moment in this, like, I am ready to flee. You know, if I'm like, okay, let's talk about what happened before your last audition, you know, what was going on. And the person is getting into that state again. So it's like, I can tell that if they could run out of the room, they would. Okay. And then sometimes there's a shift. It's almost like maybe that starts becoming reconnected to some memories from childhood. Mm-hmm. And I think performance anxiety, again, you know, a mix is a little bit of research and a lot of it is anecdotal evidence for me, but a lot of performance anxiety seems to be still linked to a lot of things that happen to people in childhood. Mm-hmm. So I think that sometimes it's the earlier experiences that become reactivated in performance anxiety. The idea that if I don't do this well, I am not perfect. There's going to be a consequence. Yeah. And, absolutely, you know, the unavoidable then can make the person veer into a dissociative state where they need to be grounded.
Yeah. And I think singing is such a vulnerable thing. You know, after working with many singers, and some are instrumentalists who then switch into singing, and they will say, this is different than when I was playing piano or playing guitar. Like, this is much more vulnerable. And so when you are doing an art form that is tied to your identity, because it literally is your body, and you are expressing something that means something to you, and you're vulnerable, what happens is what is then reflected back, if it's indifference by the people around you, or if it's negative, you know, there's negative programming that comes towards singers at times. And I think that it can trigger based on like kind of what you were saying, like the nervous system reacts and it remembers what that is, and it starts to see that vulnerability as a point of danger. And so so this is a super interesting connection to be able to talk about it this explicitly through this lens.
I had a thought, just because our last episode was about shared decision making and manual therapy and touch, and I had a thought about dissociation and consent and touch, and I'm not sure how exactly to form the thought, but it occurs to me that someone who might be having a dissociative reaction might seem to be agreeing with something, but they might not necessarily be. It might just be, I'm checked out and I'm going along with whatever is happening because this is going to keep me safe or something like that. So how do we gain consent to move forward with something like therapeutic touch when we're working with someone who might be in a dissociative state?
Thank you for asking such an important question. I would say to sort of, I'm trying to think of the best way to formulate this. To enter the relationship or the energy or the exact interaction with almost this implicit message that this is something we're doing together. Because I think sometimes, you know, I have seen in certain practices where it's almost like the patient feels like something is being done to them. And I mean, it's true. If someone is scoping you or if someone is trying to feel what's going on up here, there is something that's done to you. But I think that sometimes people fall in that narrative. So I would say really approach it verbally and non-verbally as this is a dance that we're doing together. And slow down the movements so much that the person really has all of the time to take in what's about to happen. And I would say not to be afraid to say, you know, right now I, you know, would like to sort of feel what's going on. Is that okay with you? I would like, to sort of like check in constantly. And I, of course, someone might say, oh, the psychologist thinks this is so practical, when in reality it's not. But to the extent that it is practical, to make sure that the person is always on the same page, and that if something feels off, that they are encouraged to pause, even if saying no is too hard in the beginning, to just say, okay, slow down for a moment. I'm figuring out how this feels like for me.
Yeah.
Does that answer your question? Sorry.
Yeah, yes. And I would imagine that, like, as much as you can, helping that person to be grounded before you enter any kind of touch or interaction that might be invasive, like a scope or something like that, would be important,
Mm-hmm.
Yeah, because sometimes you can tell if you're reading people well, which, when you're in helping professions, you're pretty much always kind of reading, engaging the body language and interpreting, because, you're more empathic, and you can tell when someone might not fully be there, where the attention is gone and they're not fully present. And some people can become offended by that. Like, especially if you're used to being like the expert and the authority, and I'm here to deliver something of value to you, you might be offended by someone who might not seem fully present.
Mm-hmm.
But it has nothing to do with a respect issue for you, but more to do with whatever that person's nervous system is going through.
Yeah. So important to keep in mind.
Mm-hmm.
I just have one question, actually, because I'm thinking, okay, your stats earlier was that we're talking about 1 in 4 are dealing with this. What that means is that for both practitioners, then it's going to be part of that population, as well as the people who are whether it's patients, students, whatever, clients. So I'm sure that part of the questioning then is, if you are one of the 4, what is your recourse? Do you just get triggered and have to dissociate? Like, what do you do if you are one of the 4?
You mean as the practitioner, if you are?
Either way, if this is something that I kind of just said that, like, practitioners and the client, it's a full population experience. So if you are the 1 in 4, whether you are the client, patient, or student, or the practitioner, clinician, whatever, what do you do if you're experiencing this?
You mean dissociation specifically, or feeling reactivated in some way?
Exactly.
I would say, from the viewpoint of, now I'm thinking of the viewpoint of the clinician a little bit.
Sure.
There's a couple of things. I mean, one is the trauma-informed space. There's the idea of the 1 in 4, of course, but I think because we don't know who that 1 in 4 is, my message is always, let's treat everyone, like, let's create that space for everyone. Mm-hmm. If the practitioner is feeling a reaction because of their own history, I think it's very good for them to spend some time checking in with their body again, learning like the grounding techniques for themselves.
Okay.
Yep. Thinking, okay, is this something that's going on with me? Is this something that's going on with the person that I am with? Because as psychotherapists, we're very used to doing that. That's what we call transference, countertransference. Like, if I am sitting with a client and I feel completely checked out at some point, I'm like, does it feel like it's my reaction, something that feels natural to me and that I brought into the room? Or does it feel like I was completely grounded until something started happening? So the idea of what is happening and how can I ground myself? And as I ground myself, how can I help ground the person that I am with? So that it's almost like learning our own interoceptive, complexities, and learning to bring ourselves down and then help bring the other person down.
Yeah, sure. And the other reason I was asking too is we have a lot of singers and professional voice users who listen to this podcast. We're getting a lot of feedback from them. So they are the client, students, and patients walking in. So, okay, so grounding techniques are definitely part of this story. Is there anything else that comes to mind?
I realized that we started speaking, or you started speaking about realizing the prevalence, recognizing the signs and symptoms, but we didn't get to resisting re-traumatization.
Okay.
So how does that play in with perhaps resisting the triggers that would create dissociative reactions?
I think that everything that has to do with resisting re-traumatization or the possibility of re-traumatization has to do with partially what we don't know, and partially with our own, that can also be our own reaction often, like our own resistance in acknowledging how powerful these forces are. And so sometimes we can fall into a process of minimizing the triggers or overly explaining what's going on or trying to box it up and categorize it and explain it away. I think to help not re-traumatize individuals, we really have to take in their experience as is, not be afraid to ask questions. Tell me what this is like for you, rather than this sounds like blah, 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 which is something that happens to the best of us, especially when because of our own education, our own experiences, we come in with a certain viewpoint. But I think that it's so important to just, invite the human to share their viewpoint as freely and as specifically as they have to. And, in my own experience, like I have really learned the value of really, really asking, and waiting for all of the details that help me later on, rather than thinking, oh, it sounds like this person is definitely avoiding, and then I realized, no, they're not avoiding. They really just don't identify with what could be the obvious interpretation of this.
And it occurs to me in, explaining away or over, talking about something, those could be our attempts to reassure. And something that is very well intentioned could be triggering for people. So I appreciate that, just keep your mouth closed or ask, how are you experiencing this? I love that. Because, when you are in a helping profession, your first thought is to, how can I help this person feel safe or okay? And you could be making the situation worse. So that's a very practical tool.
A powerful question. How are you experiencing this?
Yeah.
Thank you. And, sometimes, speaking of not taking it personally as professionals, I think we have to be ready to be the trigger. Sometimes really are the trigger, whether that's what we look like or our role. It's happened to me more than once that just because I'm the therapist, I was a trigger. If somebody was harmed by the previous therapist they had, I was the trigger. If I looked like somebody's bully, I was the trigger. My skin color can be a trigger. My sexual orientation can be a trigger. I have to be very, very mindful. It could be the sound of my voice. The fact that I sound Italian can be a trigger for someone. Who knows? It could be the color of the shirt that I'm wearing. And I try to keep that in mind. I don't know what triggers I bring in for this person, and I have to be open and ready.
So, if you realize that you're a trigger, do you remove yourself, or how do you handle that?
That's a really interesting question, because that's sort of where my role is very specific. Like, sometimes I say that as a therapist, I am a glorified prop for people. So if I happen to be the trigger, then we try to figure out how to utilize me in working with that trigger, in a space where we can do whatever is needed for that work. Like, the beauty of that is that with someone outside of the therapy room, the person wouldn't be able to do that, of course, because in friendships or romantic relationships or with colleagues, you can explore that stuff. But with me, I can say, okay, let's think about it. I remind you of someone that harmed you or made you very angry. Let's really go there. Like, someone else might get defensive in a different position, but in my position, I get to say, okay, let's stay with this, what's going on. I think that can be done, in different ways in other professions, for sure, not just in psychotherapy. Like, without going too into the psychotherapeutic aspects, I think that that can be done in some ways, like holding space for, do I represent something that you find dangerous? It can be reparative too for people.
Okay. Wow. Well, this is a really eye-opening conversation, because I think dissociation is something that we can legitimately see in our population. And I don't know if I would necessarily be able to recognize it when I see it, but I have an idea now of what it looks like. And I think as a default in therapy, grounding is just a really good thing to do, and it doesn't take very long.
Mm-hmm.
Yeah. And starting or finishing or even throwing in the middle a grounding activity when you need a break, not a bad idea as like a trauma informed practice that can help people to develop self-awareness, which you're going to need anyway to do voice work.
Yeah.
So thank you so much for this.
Thank you both so much.
I'll just finish up today with our closing, and I'll say, in this episode, we talked about how voice care workers can recognize and respond to dissociation within a trauma-informed approach. The 4 assumptions of a trauma-informed approach are realizing the prevalence of trauma, recognizing the signs and symptoms of trauma, responding in policies, practices, and procedures, and resisting re-traumatization. Thanks for listening. Take care.